So welcome everybody to the New South Wales Health Statewide Biobank for our seminar today. We're very pleased to welcome Dr. Peter Watson, who I'm sure needs very minimal introduction to many of the people joining us. But for those who are meeting Peter for the first time, he's the Director of Biobanking and Biospecimen Research Services. That encompasses an active tumour bank, which is the Tumour Tissue Repository. And a biobanking support unit. So Peter has also led for a long time the Canadian Tissue Repository Network, or CTRNet, that maintains and operates biobank quality platforms, including the CTRNet Biobank Certification Program. And it is the CTRNet Biobank Certification Program that was adapted in 2016 and opened in New South Wales, and that's been continuously running here at the Statewide Biobank. So Peter is also Deputy Editor for the international journal Biopreservation and Biobanking. And over the past 35 years, a lot of his research has focused on the molecular pathology and treatment of breast cancer, but he has also published very extensively on biobanking standards, operations and sustainability. And I think actually one of Peter's papers that I think he published in around 2013 had a really big impact on, I remember myself and Amanda Rush when we started working on biobanking, and that was his paper that described different models of biobanking according to access, the access policy. So yeah, that's, I think Peter's work has influenced me for a very long time. And today he's going to talk about something that I think is really very relevant in today's environment. And that's about really thinking about how we can move from having very large collections of samples that may not, always be used, to having access to a broad range of participants through permission to contact models. So Peter, thank you very much for joining us, and we're very much looking forward to hearing your seminar, and then we'll have some time for discussion. So thank you.
That's great. Thanks very much for the intro, Jenny, and it's nice to be amongst friends. And today is Remembrance Day in Canada, and I understand you had your Remembrance Day yesterday, so it's certainly a week for thought. So let's jump into my talk. So as Jenny has introduced, I'm going to talk about really the evolution of the operational focus of biobanks going backwards and looking forwards, from inventories to services and on perhaps to libraries based on a patient contact systems, which I think are becoming more and more important. So with that, let's just get the slides working. So first, just a couple of sort of specifications for everybody, because the word biobank is a very broad thing, and there are lots of types of biobanks and models. They're all important and useful. What I want to just specify is I'm going to talk mostly about the kinds of biobanks that need to connect with and enroll patients, rather than the equally important kinds of biobanks that need to connect with normal people. But there's increasing overlap, I think, as we merge together different areas of research moving forwards. The second thing is I'm going to be talking mostly, I guess, also about disease specific biobanks and the ones that have emerged over the last couple of decades using the classic kind of inventory focus model that was initially developed in the 1990s and early 2000s and is certainly still prevalent. So with that sort of specification, think broadly when I use the word biobank, but understand where I'm coming from. And as Jenny said, also a lot of my experience has come through both clinical practice as a pathologist and biobanking in the cancer research arena, but I'm passionate about biobanking across all health research. So with that, biobanks are they're one of the very important research infrastructures. Like all research infrastructures, they exist to support research, and that's their raison d'etre. But of course, all forms of research infrastructure, share something, and that's a life cycle because research is dynamic and is constantly changing. So what changes over time for biobanks? Well, there's changing research demand. And so this chart, the first of two charts, it mostly draws again on my interests and studies in cancer research, but I think it's pretty applicable across health research. And on the left, you can see the main categories of biospecimens, tissue and blood fresh, blood and tissue frozen, and tissue that's been processed into formalin fixed paraffin embedded blocks. And on the right, you can see the kind of sources for research for those main categories of biospecimens. For fresh, it's prospective biobanking by a range of actors. For FFPE blocks, it's mostly through some form of access to clinical pathology archives. And for frozen materials, blood and tissue, it's predominantly through access to population model and classic model biobanks. And you can see the kind of proportions of sort of demand depicted in the 1990s on the left. And then if I superimpose what our studies have taught us, looking at the literature in multiple studies, those proportions have changed over time. Now, this is a proportional chart. It's not absolute numbers. But what we've seen is really a diminishing proportion of research is interested in frozen blood and tissues, particularly frozen tissues in inventory model biobanks. There's an increasing demand in research for access to pathology archives and for fresh specimens through prospective biobanking, again, conducted by a range of actors. So combine that information with this information, which is a sort of a summary of the current balance between supply and demand for frozen biospecimens that are stored in inventories. And the numbers here are standardized for the numbers stored per million population in relatively affluent countries, where a lot of our research is based on locators and the biobanks identified within those biobanks in affluent countries. But still, these are certainly applicable to places like Canada and Australia. And so getting a handle on the numbers of specimens stored and the numbers that are actually being used in research is complicated. You can go to some of our publications if you want to see the calculations. But the punchline shown on this slide is we think there's roughly a 10-to-1 ratio at the moment. Now that ratio is healthy, but in my view, it's too large. And I think the important thing to note is that the left side is going up and the right side is going down when we're talking about frozen biospecimens in inventories. And so I think that's a sort of something that biobanks need to think very hard about, is that there's a change in this demand. I should just emphasize at this point that none of the information I've covered in the last couple of slides is meant to say that classic model inventories aren't still very important for some sectors of health research. Obviously, they're incredibly valuable for sort of research that has a retrospective question that wants to study biospecimens combined with data that's been accumulated already, treatment and outcomes data, for example, associated with a tumor specimen, to rapidly move areas of research forward with some information before you can move on to the more expensive and more convincing prospective study kind of work that culminates in clinical trials. So frozen inventories are still very important. It's just the proportion of demand is falling. So what are the drivers of this change in demand? Well, certainly in cancer research, I think there's three main drivers. The first of those is there's an increased demand for complex biospecimens. So this is a term for specimens that are paired or linked temporally or geographically within specimens or within patients. And these are the kind of specimens that are actually essential to interrogate questions related to tumor evolution and heterogeneity. And the important thing is that you won't find complex biospecimens in most classic model biobanks. These are the kind of specimens that are beginning to accumulate in clinical studies and clinical trials that are designed and funded to collect those kinds of specimens. The second driver is the increased demand for fresh biospecimens. We've really experienced it locally. I know that there's data published by the CHTN showing this increased requirements for fresh biospecimens. And I think a lot of the driver for that is the new technologies for cell isolation and the new requirements for functional phenotypic analysis within specimens, and particularly the emergence of the new exciting field of interrogating tumor immune interactions, and in other diseases, the interaction between disease and the immune system. And the third major driver is access to paraffin blocks. This isn't necessarily new, but it's been steadily increasing over the decades. And obviously, this is partly driven by technological advances that mean we can extract reasonably high quality protein and RNA from paraffin blocks and do omics, apply omics techniques to this and yield very important data. But this is also because obviously these are the kind of specimens that allow sort of microscopic lesions and a range of pathology to be analyzed. And also it's the kind of specimen that if you're trying to develop a clinical assay, you need to be able to apply that assay to the clinical material. And so that leads, if you start in research with studying paraffin blocks, there's increased translatability to a clinical assay. And the last point related to paraffin blocks is you reduce selection bias. Now let's just dwell on this last point, reduce selection bias, because I think it's perhaps one of the most important drivers, and two, it's relevant across all health research. I think we really need to acknowledge that there is a significant bias in classic model biobanks. Yes, they're important. Yes, they can only collect certain kinds of specimens, remnant specimens from the clinical pathway, but that introduces significant bias. For example, this slide is showing you data from the Manitoba Breast Tumor Bank. Now, this is a well-established bank. It's been in operation for 4 decades. It supported leading national and international breast cancer research, but its main stocks were compiled during the 1990s. And if you look at the left panel, you'll see that through the 1990s, the proportion of breast cancer specimens from which the bank could collect a research specimen and process it and put it into the inventory has gradually fallen from about 70% in this panel down to about 30% at the end of the period, and that's roughly where it stayed. Now, on the surface, that isn't really a big problem. And in the middle panel, all the tumors kind of look superficially the same, and in the middle panel is showing you that the samples, the average tumors collected every year have the same tumor cellularity. So what's the problem? But the problem is that the biology has changed of the average specimen collected. So on the right panel, you see an indication of changing biology in the typical specimens collected by this bank. At the beginning of the period, you can see the majority are strongly ER positive. By the end of the period, a large number, the average tumor is borderline ER negative collected. So there's actually a real change and a skew and a bias in the biology of the kinds of specimens that are being collected, stored in the bank, and are then released as part of research cohorts. Needless to say that for anybody who's not involved in breast cancer, the clinic or research, there has been no substantial change in the proportion of breast cancers that are ER positive or negative over this period. So this change is all a reflection of bias in the collection, which ends up as bias in published research. And so studies supported by these types of biobanks have inherent biases. And if you look for it, you find the bias in the literature. So on this slide, this just shows you the top 2 rows of the table and the same two rows showed depicted graphically below, shows you the distribution of breast cancer subtypes in cohorts used for two representative translational studies published in 2016 and 2020 from Canada and Switzerland. Now compare the proportions, I think it's easiest to look at the graphic below, between these translational studies and the proportions of different breast cancer subtypes from comparable types of studies, but based on population-based studies from North America and from Europe. And you can see, just visually, that there's a significant difference in the proportion of high-risk breast cancer subtypes represented in those translational studies as compared to the gold standard, which is population-based studies in the different, in Europe and in North America. So this, I think, is a good illustration of the kind of bias that can creep into research because of the constraints around establishing classic biobank collections. So back to evolution of biobank operations. Well, our biobank, which has been in operation, in fact, from 2004, began as a classic model biobank. For many years, its focus was on its inventory. And on the left, you see the sort of depiction of the relative time and effort of our operations and our focus of our operations. As you can see, it was all inventory focused. But over the years, we've gradually evolved to the point that we are today, and we've been in for maybe a decade, where we're not inventory focused at all. We're focused on other things. So the inventory focus is about 20% of our operations. Collecting prospective custom collections for individual research studies is about 25%. And the other 50% is a whole range of biobanking services, processing, storing, consenting for clinical research and studies. So we've really changed from an inventory to a services biobank, and that's where we sit today. Now, of course, today it works very well. We're actually very busy, incredibly busy over the last 1 or 2 years since research recovered from the COVID pandemic and have turned more to biobanks like ours to move ahead with their research. So it's fine right now, but I think we see the signs that we actually need to think about evolving further going forwards because of changes in relative demand. So what do I think we and the whole system need to think about in terms of preparing biobanks and biobank infrastructure for research over the next decade? Well, I think there's really 3 major aspects to this. The first 2 are already underway and are more system level changes. And the third is one that really needs to be better developed and is more at a biobank level of change. So let's just talk about these 3 areas of evolution. The first component is that we need to better connect all collections. And here I mean the way all specimens and data are collected by biobanking activities at the outset by all forms of biobanking. So that's, yes, biobanks, professional biobanks, but it's also lab projects, it's cohort studies, it's clinical trials. Anybody in the research arena collecting specimens is doing biobanking, and they're creating very valuable collections for different areas of research. But what we haven't done, looking backwards, is really connect the way these collections happen. But this has and continues to be one of the missions of CTRNet. And this we try to accomplish, and I think we're moving well along this direction through the Biobank certification program, which, as Jenny mentioned in the introduction, has been adapted and adopted in New South Wales. So this is a program that intentionally targets all forms of collections, and it targets the collections with a mix of continuously updated standards and education based on international best practices, and in order to build common knowledge across the whole research arena so that we're all moving towards collecting of our specimens and our data in a similar fashion and understanding how important standards are in that process. And of course, this program, I think, has been pretty successful. We have well over 150 biobanks enrolled since 2012. 25% of those are international banks from 20 countries. The other 75% are Canadian banks, which obviously is a primary program here. We continue to see a lot of activity, 65 new registrations and certifications per year, and a lot of renewals. And the large numbers, and this is the most important piece, I think, large numbers of the staff and membership of these biobanks create accounts and access the education and learn about how to biobank using common knowledge and standards. And of course, our job in the background with this kind of program is to keep the program running and maintained. So we're regularly updating all the components, and that's shown in the chart below. The second component of evolution that I think we need to focus on better is to connect and verify the data. And that's the data both within the biobanks and the data that comes out of the biobanks. Now, of course, this, like many other networks, has been one of the missions of CTRNet for 2 decades as well. And in common with other networks, we've addressed this in different ways. We've established data standards, we've established locators, we've done other things in this space, but unlike other networks, I think, we have also invested a lot of energy into building and disseminating an open source academically supported biobanks bin system in order to try and standardize the data within and between biobanks. And that system we named ATOM, and it's been in place for many years. The first version was launched in 2007. And now in 2025, we have large numbers of Canadian institutions have adopted this as a central biospecimen management system. There's 71 instances supporting 80 biobanks and consortia, and large numbers of samples and participants are held by this framework. But unlike our certification program that I think is still current and needs maintaining, but the model still works, we recognize that changes in research, and particular data technology, means that this ATOM system needs to evolve. And so the Quebec node of CTRNet has turned its mind to building a replacement system. A year or two ago, this system is now named as MyBioKey, and it's going to be launched probably within 18 months as a first beta version, as we now, certainly in Quebec, have a 6-person dedicated team working on this project. So, of course, key improvements to launch a project like this that we recognize if we need a refreshed and a new architecture in terms of programming language to provide security in an appropriate environment. But the key features that we think will improve on ATOM will be, the institutional and cloud-based solutions and capability for partition data within the database. And then also obviously adopting new technologies like blockchain tracing and AI-ready technologies, and integrating data standards through different APIs. And also, while designing this and developing this new system, it's intended to be validated and documented so that we will be able to seek ISO certification for the platform. So this is coming soon, and I'll leave that there. So the third component that's necessary for evolution, we've talked about 2 system level components, but the third component that we need, I think, at the biobank level is to actually improve the front end of biobanking operations. And that's the way all forms of biobanks engage and enroll participants. Now, you've seen this diagram before in several of my slides. I just want to remind you of the purpose of the diagram, as it simply reminds us that people become patients. A subset of patients become very generous donors of their biospecimens and data. That is collected by a whole range of entities conducting biobanking in order to feed health research with this critical fuel. Health research generates knowledge on the basis of that fuel, which creates better health, which converts patients back to people again. So it's a simple cycle, but the problem is that the actual real process whereby all these biobanking entities engage with and enroll or try to enroll donors is a mess. That's my view. It's a mess for three major reasons. There are temporal gaps, there are geographic gaps, and there are narrow interests. Temporal gaps is when the ability to collect isn't synchronized with the actual availability of the donor's biospecimen, so there's a time difference. The geographic gaps are when the donor's in one hospital and the key research study is located somewhere else in another organization, and you have those inter-organizational and geographic barriers that rise up. And the third issue is narrow interests of individual research studies. Now, I don't mean narrow in a pejorative way, because that's the way we design our competitive research structure, but they're still narrow interests of individual studies because they operate independently, they compete to get in front of donors, and they maintain their own databases, and these aren't shared across different studies. So these, I think, are real barriers to enrollment. So the solution is the third part of evolution in my title slide. It's a biolibrary. A biolibrary is something we actually developed and operated in BC many years ago, but we haven't been able to sustain it for a variety of reasons. But the biolibrary is a specific type of infrastructure. It looks a bit like a biobank, it sounds like a biobank, but it's different. The main components are a contact system, an enrollment system, and a biospecimen collection and distribution system. And this whole platform is a distributed platform established within multiple centers where there's active healthcare across a region. Now, what I've just said and depicting here in the slide, it might sound a bit like some forms of biobank network. For example, the CTRNet in the US, which is arguably one of the most successful types of biobank infrastructure around. But the biolibrary differs with some key features, and notably it differs in that it has shared governance. The governance is shared by all those entities conducting biobanking. So it's not run by a biobank making all the decisions. It's run by a shared governance representing clinical trials, cohort studies, lab projects, and biobanks. The second difference is the whole platform is anchored on a contact system. And the contact system is the key because it allows patients to lend their contact details and research to borrow their biospecimens. So let's talk a bit more about the enrollment issue and before we talk about the contact system. So enrollment is a massive problem for all clinical research. We all know, and it's been known for years, that less than 5% of patients are ever enrolled into a clinical trial, and only a few more get enrolled into other forms of clinical studies. So research is really limited. It's limited by a variety of things. It's limited by the opportunity to approach patients, by individual study constraints, the effort and cost of consenting, and it's also limited, as we've talked about by study competition and those siloed contact lists. But the problem also exists for patients. It's not just researchers' problem, it's patients' problem. Patients, only a few patients are actually ever approached and asked whether they want to actually participate in research because of the way we set up our current research systems. So, and when they are approached, there's a very small number of patients have to spend a lot of time absorbing jargon, study rationales, inclusion, exclusion criteria, and of course, essential but long and time-consuming consent forms. So I think we all should ask, because we're all part of the public really should ask, what's the real message for patients? Is the message that if you're a gray patient, the massive 95%, that research actually isn't interested in your problem. We're only interested in those green patients that we can find and are feasible to approach and consent. So the message is actually a lousy one. It's that we're not interested in most people's disease. We're only interested in ones that fit the particular studies that we have on at the moment. The second problem that we need to also recognize again is that we can't really translate research with this kind of bias in our enrollment. And so the third reason that we should be asking questions is, why should patients and the public vote to support research and clinical research if they've never been engaged, if they're not involved? So it's not surprising that we're always trying to survive on support from governments and foundations and other levels because nobody's heard of research. We don't approach enough people. So now we get to the solution. The solution is a platform called Permission to Contact. The solution is to switch the focus into instead of obtaining consent, to obtain just the permission to contact. Of course, permission to contact, therefore, is not consent. It's a permission. It's a simple question. It's easy to understand. And it's also seen by patients as a meaningful engagement in research. But it isn't consent. It's an agreement by an individual for a minimum set of personal health data be collected and stored, access to their health records for pre-screening by the platform for eligibility for research studies that come to the platform. So it's an independent broker. And it's permission from the patient to be contacted by those specific research opportunities that are identified by the platform to complete consent. The origins of this idea actually sprung out of a collaboration with Mike Burgess and his team at UBC back in 2007. And with Mike and the team, we held a series of public engagement events in British Columbia that used the tool of deliberative democracy to examine views on how patients should be involved in biobanking. And one of the areas of focus was on how the selected public that were deliberating felt patients should be approached for consent. So this was a really useful and eye-opening exercise. And it made us think very hard about how we could improve the process of enrollment. Now, of course, the process of enrollment is to some extent constrained by the requirements that are laid out by our national ethics policy and the position, certainly in Canada, that research involving human biospecimens and data requires consent. This is a different position, for example, than other countries to the south of us. But after considering the deliberations, it became clear that there was actually an opportunity to improve the process of obtaining consent if we considered the different component parts of consent. Consent has lots of different protocols that are practiced, but it also has these three key phases. The first phase, when you think about it, is referral of the potential patient from the healthcare arena, which has the right to know that somebody is a patient and what their condition is and what they're facing, a referral from there to research, which doesn't have the right to know unless that appropriate referral is made. So referral is the first step in consent. The second important step is the preliminary interview, that fact-finding between the study and the potential participant around whether they're if they're specifically interested, whether they fit the broad requirements of inclusion criteria, and to determine the format for obtaining consent, whether it's going to be electronic, in a face-to-face discussion, and where that should happen. And then the third phase is the actual consent interview, where details are provided, there's a discussion, and for many patients, there's a confirmation of informed consent. So it's actually a three-part process, but often several of, two or three of these components are merged into one, particularly if it's a clinical study and clinical individuals conducting both the healthcare and the research wearing different hats. But when we stepped back and thought about it, and we thought about what we'd learned from the deliberative engagement with the public, we realized that there was actually an opportunity here. And we realized the opportunity was because it's a Wild West landscape for consent, which we've already talked about. There's all these studies trying to contact patients and all trying to run through these same processes of consent to enroll a participant in study X, Y, or Z. So the opportunity is to make a platform out of that first step of consent. So by doing that, it means that all patients who are undergoing diagnosis procedures and follow-ups can be approached by this platform for permission to be contacted and all those details that I listed in an earlier slide. So you convert those gray patients, all of them, convert into green patients who are already, they believe they're participants in research and they're almost participants in those studies because they provided permission to contact, but they haven't been connected with a particular study that will be relevant to them. So that's the first benefit. The second benefit is all those studies are not approaching all those patients. They're approaching the permission to contact platform with their requirements, their inclusion, exclusion criteria. They work with the platform to identify the appropriate participants for their study and are then provided with contact details to complete the consent, or the platform can do that as a service. So you're removing that hassle experience for the patients of being approached by all those different types of study, and you're converting most patients into what they believe are already participants in research right at the outset. So with that concept, does it work? Well, we developed and implemented the first prototype many years ago, back in 2007-8, at our cancer center here in Victoria, British Columbia. We developed, evaluated, improved, and ran this prototype for many years. We learned that it really was a working and workable platform. We also learned things we hadn't expected, that it really engaged our clinical staff in shared activity with research. It meant that we could actually create a population-based blood biobank. And we also really learned from patients and researchers that they felt it opened research opportunities for them. So as well as running that prototype, we then were able to secure funding, and we went out and we piloted this model in different healthcare settings. We piloted in other cancer centers across the province. We piloted in different types of heart clinic. We piloted in general surgery clinics and also in maternal health clinics. So we learned that in all these environments, the PTC model worked very well and was successful. We then moved on, and several of the 5 health authorities in BC became interested and implemented in 3 of those health authorities different types of model of permission to contact platform, which still exists today. And we also learned that you could modify the mechanism of delivery. The original prototype was based on using roving interns, but several of these models became very successful and in fact lower cost to operate by involving healthcare staff, so the clerks and nursing staff, in asking and documenting the permission to contact question. So we enrolled thousands of British Columbia patients over many years. So we learned a lot. We gained experience. We published multiple papers, and you can go to these papers to sort of learn more details. But a summary would be that there are multiple benefits to this type of platform. It's acceptable to patients and staff. It's efficient. There's engagement by everybody, and the enrollment is really improved. So let's just show you briefly a little of the data. Well, from the point of view of a tumor bank, our tumor bank in Victoria, we saw a 40% increase in referrals immediately after implementing this permission to contact platform as part of our enrollment workflow for the biobank. So that was a real improvement. Our colleagues in epidemiology research were amazed to see a 50% increase in response to lifestyle surveys. So these are cold surveys sent out to individuals who had agreed to be contacted about research. And so clearly people felt engaged in research and primed and ready and willing to participate. And we also realize that there really was improvement in the cost and efficiency of compiling tissue microarray cohorts, for example, for clinical studies. You can see it's historical data, but the typical biobank cost for consent in our environment by using a preoperative protocol is about $90 per consent. It's less for a post-op consent, but obtaining consent or completing consent after a permission to contact, the combined cost is significantly less. So let's just drill down a little bit more on that costing, because how efficient is this, I hear you ask. If you obtain permission to contact 1 year and then maybe several years later try to complete consent on selected individuals that have said they're willing to be recontacted. So we were interested in this issue of how long the permission to contact would be of high value in order to complete consent. So to do that, we compared enrollment by the standard consent with permission to contact plus completion of consent over a period of time by trying to compile a cohort of 200 breast cancer patients for a particular study. We broke that cohort down into about 100 of individuals selected who had low risk in situ disease and about 100 who had very high risk form of invasive cancer, triple negative breast cancer patients. And so right at the outset of the study, we selected our cohort. We sought permission from or approval from the Research Ethics Board to recontact these patients who had been provided permission to contact up to 12 years previously. We were granted a waiver of consent for approximately 50 patients who are now deceased, and we were able to use their materials from clinical pathology. And then we tried to complete consent on the other 150. On the left, you can see, surprisingly, the consent outcomes were very similar between the low-risk cohort and the high-risk cohort. A very similar number provided consent, and a very similar number were unreachable. So if we combine the data, that's what we've done on the right-hand side. And you can see the combined data for this 200 patient cohort, now 150, where we're actually having to try to recontact and obtain consent. On the left column, you see our kind of performance for the standard biobank if we were trying to compile a cohort of 200 patients based on standard biobank consent. And on the right, you can see 3 columns for trying to recontact and complete consent, I should say, on individuals who provided a PTC between 4 and 6 years, 7 and 9, and 10 to 12 years. So as you can see, that the proportion that provide consent over time remains pretty steady. And yes, the proportion that are unreachable gradually increases over time, but that didn't affect the numbers who were able to consent at a roughly 50% efficiency rate, compared with about 85% efficiency for constructing a cohort directly from a biobank. But there's a very different cost to doing this, and there's different issues in the selectability of individual patients for a particular study. So we feel that the end result is, despite the passage of time and loss of contact for some individuals, this really wasn't a problem and left PTC plus completion of consent as a highly efficient, viable way to construct cohorts for clinical studies. But is PTC really a panacea? Well, no, obviously nothing is perfect. Different enrollment models will always have pros and cons. So standard and study-specific biobanking consent is still essential. For example, I've said optimal, but it's actually essential, where specific interventions are going to occur to obtain specific tissue samples that aren't going to be obtained in the regular course of clinical care. So there are some areas where it's more than optimal. It's essential to obtain consent using the standard model at the outset. But it's only optimal for research where there's specialized timing and processing is required. But again, there are a lot of drawbacks to the standard consent mechanism. The drawbacks we talked about earlier of timing and confusion for patients, high cost and inefficiency. Whereas PTC plus future completion of consent is optimal for a lot of research that uses remnant biospecimens where the timing approach is flexible. And the drawbacks that you can think of the added step and the need to complete consent don't actually seem to be a big problem as we've tested ourselves. So one of my last slides here is just to remind you that why would you think about enrollment by PTC as opposed to standard enrollment? Well, one of the main reasons is this reduction of research bias. Standard enrollment leads to a very small number who are actually consented, and out of that very small number, a very small number can be selected for research cohorts. Whereas enrollment by PTC, the vast majority of patients will provide that permission. They become permissioned and engaged in research, and you can then select from this large number of individuals using particular research criteria to create far less biased research cohorts. So the summary of value, as you can see on the right, a number of summary values for research around expanding access down to enabling training of individuals involved in the PTC process. At the top, you can see another major value as the patients become actually part of the solution because you're approaching everybody to participate rather than just most of them being a focus of the problem because we're not actually studying their disease, we're only consenting a small number. And that increase in patient engagement leads to significant increase in patient support and ultimately impacts on improvements in care. If you want to learn more about the PTC platform, we developed a toolkit. It's available through our resource center or through our partner organization, the Canadian Network of Networks, N2, so you can go to those sites and learn a bit more or download the toolkit. And finally, a shout out to our current Biobank funders and partners across Canada and showing you the two key links for biobanking in Canada. Thanks very much, and I will hand the mic back to you, Jenny.
Thank you, Peter. That was a very inspiring presentation. Thank you. I'm wondering if people have got questions. Yes, please either pop up your hand, or if you can't ask the question where you are, feel free to add something to the chat. So I've just seen, I've got a question from Candace here. Have any automated systems been trialed with permission to contact, such as automated emails, texts sent to patients attending a clinic, or service and patients responding online?
There are several models. Why I said we developed it and ran it for a certain number of years is that several alternative models were developed and implemented by different health authorities. I think those models have different pros and cons, and we could talk more about that another time. But for example, one of the models was setting up if you like, an online database that individual patients could self-refer themselves to, and at the same time, researchers could self-refer their studies into this database, and the database does the matching automatically, and matches patients who tell the database what their condition is and what they're interested in with research that says they're looking for patients. So that's another sort of, if you like, an evolution of the model, which I think it has its own pluses and minuses to it. So there are other examples of, if you like, trying to create electronic models that everybody can just go to and use online. And of course, there are other tools that can be distributed to individuals on first approach to enhance their kind of information and knowledge about research and what studies are looking for them. But thanks for the question.
Do we have, I see Amanda has a question. Yes. I'm wondering if you ever see a time when the permission to conduct step could be incorporated into a patient's medical records. Yes, that's definitely something we're thinking about here.
Yes, we actually tried to do that quite hard. We ran into kind of logistical problems in that the people designing the new health charts didn't want yet another flag in the chart, and and what the significance of that flag could be, but one of our health authorities actually did successfully do that and include that, and then at the same time enabled certain levels of researcher, if you like, to have access to the clinical chart, to find those flags and then contact the patients. I myself prefer, I think the idea of a flag in the healthcare chart is excellent, but I think actioning on that flag, I personally prefer the action to be limited by governance rules to a broker platform, such as a PTC platform that has the initial contact with individuals and the expertise to appropriately distribute or actually recontact that patient with a consent form on behalf of a study, for example. So I think, and the other advantage there is you don't have that wild west of lots of studies finding a flag in the chart and all going to contact a patient for consent for their study, which of course is something that isn't fictional. This is exactly what happened during COVID, and it was a real mess in that people were just contacting this high research demand type of patient with COVID in a hospital through equivalence of flags in the chart. So I think we've seen that doesn't work well. I think having a flag in the chart's good, but there should be rules about who can take action over that.
Yeah, who can sort of operationalize that. Yeah,
Yeah.
I think that's a very good point. And that's, yeah, I think there's obviously probably going to need to have a lot of discussions down the line, particularly in light of the development of the single digital patient record here in New South Wales. I mean, that's intended to sort of, increase capacity for research in just the way that you've talked about by reducing bias, but I know that there's a lot of thought being given at the moment in terms of that governance of access to information and who can act on information. I just popped in the chat a couple of papers. So one of them, Peter, was your 2009 paper, because I think that's one of the open access ones. But when you were talking about the rate limiting steps and the issues around recruitment, I reminded myself of a couple of papers that we'd read a few years ago about, again, rate limiting steps, and over, I think it is this participant recruitment, patient recruitment. And as you probably know, most clinical trials fail, I understand, because of failures to recruit. So it's a really significant problem.
Yeah, it is. And I just want to jump back into emphasizing again that even though I don't have hard data on this, that I think it's a significant problem for everything that we hold dear, which is health research, that most of the public's never heard about it. They've gone into hospital, they've had a condition, they've been helped along the way, and then they've left and gone back, and nobody ever came to them and said, are you interested in being involved in research? Because of the way we structure our research. So those same people are the people who are voting every time we have an election, every 5 years. And why would you vote for something that you're not involved in and never heard of? So I think that's one of the reasons why health research struggles to sort of be heard amongst all the other important needs for funding.
Yes, and I think something we've talked about this in the past. I've been, I guess I've seen the value in opt-out models, where just, the whole population's kind of pre-consented in some way. But I know that your argument has been very much, well, firstly, how much is this really an informed model of consent, but also the advantage of engagement, the fact that, engagement has value as you've described.
Exactly. If you're going to do opt out properly, you've got to invest in disseminating information that this is how the system works, and that isn't cheap.
Yes.
And so it's not zero cost. There is a cost to it. And yes, you hit the nail on the head. I think if you haven't actually asked somebody with a simple question, make it very quick, simple, cheap for everybody, the patient and the researcher, but ask them, and then it becomes real. And if you don't do that, so opt out, I think, works for a bit, but you don't reap those other benefits.
Yes. And I would say, I'm going to go to another question in the chat in a second, but opt-out seems to work well in countries with very high rates of trust, community trust. And obviously developing that trust is, of course, a lifetime of work, really. It can work, but there you have populations that by definition are kind of probably already aware of the benefits of participation in research, but that's because of a whole, that's because of the social structure and how government interacts with people, and that's not ubiquitous around the world, of course.
And it's easy to lose that trust, as we've
Yes.
seen very recently in other
Yes.
arenas in different countries, and certainly in the UK going back to the year 2000.
Yes, yes. I'm going to go to Amanda's question about, in terms of confirming permission to contact, particularly around children who've turned 18 or people who've reached a, age of, majority.
I think I'm going to duck that question because I'm not an expert in pediatric research and the that transition area. I turn to my other experts, but we have, as you saw, piloted and used PTC in maternal health clinics very successfully.
Right.
But that's, I guess, with the mums, not with the children.
Yes, not with the bubs. Yep.
Yeah.
Do we have any other questions? Anyone's got their hand up that would like to ask anything? Michael, thank you.
Hi, thank you so much, Peter. Really got me thinking from an infrastructure point of view. Obviously, I'm not a biobanker, but I am a scientist, and I really like the advantages of overcoming biases. That's a really important part of improving the science that we do, at the same time as engaging the public. So 2 great wins on both sides. So from an infrastructure point of view, obviously there's probably cost neutral or savings to be had in the consenting process, because you have increased engagement because of the staged process of enrolment through to consent. And do you also see that there are savings possibly to be had in holding samples in case of projects? So as sometimes when we consent or seek consent, we take samples at that time for prospective analyses, but given that there's also a shift towards a need for more fresh samples, that this is much more amenable to collecting the appropriate samples for a particular project, but then aren't necessarily held in perpetuity and then can be recollected for a different project.
Yeah. So taking your last, just to address both points, absolutely. On the second point, you establishing a sort of a collection and distribution system like a Biolibrary that serves all research that wants to collect, has enormous advantages for exactly what you've said. I mean, if somebody's just collecting in their own hospital for their priorities and their researchers, those priorities aren't the same as the researchers across the street. So they may or may not collect those samples. They may or may not store them. They may not have fresh material that are available, and nobody may know. So having a common, collect enrollment and collection, infrastructure that serves all those important entities that want to do biobanking means that you improve the efficiency across the system. The example I always say is if I'm a researcher that wants to collect left toenails from across the province, how do I do it? How do you set that up as a new researcher? It's complicated. It takes you a lot of time. You run into all that kind of some competition in some places and no competition in others. Whereas if it's a collection and distribution framework, you go to the framework governed by everybody, and you thrash it all out through peer review, just like we do with funding. So you figure out the priorities and what the important studies are and how you can share biospecimens. And if there's specimens going to waste in one place, but would be valuable somewhere else, you can move them sideways. So I think there's enormous efficiencies. Just going to your first question, I want to emphasize that what we learned and we've documented in our studies is actually cheaper to collect a PTC and then complete the consent than do the consent right up front. And one of the reasons I think that's surprising, well, PTC can be done very cheaply. And the second thing is that when you come back to an individual, even if it's the next day or if it's 10 years later, most of those individuals have said to us, yeah, I remember I gave permission to be contacted. You've come to me with a research project. Where do I sign? And so the process, because the patients have been primed, is much shorter and easier. And of course, you can, because they've given permission to contact, you have easier mechanisms to contact them than you might enact if you're trying to do standard consent in the clinic. So it's actually cheaper, even though you lose some patients over time because the chart, which we rely on in our models, loses that contactability.
Thank you.
Thank you. I think we might wrap it up there on that note of costing less, which is of course dear to everybody's hearts and particularly our funders. But Peter, thank you so much. That was a wonderful presentation. I'm sure that many people will revisit the recording, including myself. I think it's very inspiring to learn of just the amount of time that you've invested in this. You've really tested this model, and we very much hope that we can make something like that work in Australia. So
Great.
Thank you.
Thanks very much. It's a pleasure to be back in New South Wales virtually.
Yes, it's wonderful to have you.
Great.
Thank you. Thanks everybody for attending. Yep.
Cheers all.
Bye. Bye-bye.